Today my talk will be on cardiovascular disease story. I'll try to give it in 4 scenarios, case scenarios, and what we can do to tackle this problem. December 2003 in Bahrain, Jocelyn Diabetes Center from US, Boston, and Gulf Diabetes Specialist Center. They tried to tackle this problem. And this is why, because of the high prevalence of diabetes in our area. They established the first institution in the area to tackle this problem, and this is the building where I'm working. It's really trying to tackle the biggest epidemiological tsunami, and it's still ongoing. And what our team doing, we try to be with the community, trying to help diabetic patients in any way we can do, whether clinically trying to treat patients, preventive, with association with Royal Charity institutions, with the Ministry of Health, independent, with the independent institutions. During this almost 15 years, we succeed to do some minimal work, but a lot of work being requested. Because 1 in 11 in the whole world, while in our area almost 16% epidemics, and we expect to get 600 million people with diabetes in low and middle income countries. Really, it is a big problem that you need resources to tackle this big problem. Especially if we know that 30 to 80% of these people, they are either unaware about their problem or they are neglecting or undiagnosed. So let's talk about one lady, Assaad. She's 40 years old, female, with history of gestational diabetes. It's very important for high-risk group, smoker, overweight, hypertensive with dyslipidemia and gout. If you look for her BMI and HbA1c is 5.8, is it optimal for you? Is it good or not? Her GFR is 78, blood pressure is 150/90. What's the solution for this patient? There is no albuminuria. So is it metabolic syndrome? Did we treat metabolic syndrome properly? And what we can do to prevent cardiovascular events in our population? If we go to the physiology, and you look for the intima here, you can look for the monocytes migrating to intima and penetrating with the oxidized LDL engulfment, forming a foam cells with the smooth muscle migration to make streak and plaque, which will be vulnerable for any time to get the event. So what we can we tackle this problem? Really, diabetes leads to cardiovascular death through both atherosclerotic, MACE events, and should not forget heart failure. Both of these share common pathophysiological mechanism. Oxidative stress, inflammation, insulin resistance, obesity, and MACE events which lead eventually to cardiovascular or cerebrovascular death. So what cardiologists, and there is good chance we have cardiologists here today, what they can do for our patients. In our institution, we recruit 4 cardiologists to support us. Some people, they look for electrophysiology, but we are our intention to look primarily earlier for the nuclear medicine, then stress echo, MRI, whatever you have facility, but the end of this you will get for coronary angio. And if you look for the lesions here, in A, you can see it's critical by angiographic way. And here, it is mild While if you do physiological study for these lesions, by introducing a catheter here, and then you measure the pressure before this plaque lesion and after, you can change your mind. So the case here, treated medically, and here differently, they treat them by using PCI. So here is confirming your diagnosis by doing this electrophysiological. But this is only representing 10% for epicardial coronaries, 10% of cardiovascular events. What about microvascular events? The 90%. There is now a lot of techniques like thermodilution. They try to do that, but what is the best way? The best way, we should look for the risk factors and would treat the problem earlier before the troubles. In this study, they tried to look for the correlation between diabetes and coronary events. So as we are looking for evidence-based medicine, you can see clearly here the hazard ratio is 2 and 2.3 for coronary death. Non-fatal MI. It's more with the stroke. So you should be careful for thrombotic stroke. We should not just focus on coronary events, we should be careful also for stroke. But what it was amazing that we are neglecting women's, because in this study, they show that women, they have more risk for coronary events, especially fatal events. And which age group? Between 35 and 59. The age group I presented with you earlier, Assaad patient. In this registry, Swedish National Diabetes Registry, they look for whether if we treat diabetes, we can prevent these events, and what we are doing in diabetes. We try to control HbA1c. This is the colors you can see here. Each one indicate a marker. LDL, cholesterol, then the albuminuria, smoking. Further than this, we should try to control the smoking, quit smoking. If we are succeeded, yes, of course. If you look here for these fifth factors, when being controlled, you can almost be equal to the control group. So what you want to do, you want to do intensive control for these parameters. Really, diabetes substantially increase vascular risk both men and women, and as I explained to you earlier, women are more vulnerable, and you can look here for hazard ratio 3, while it is 2 for men. It's not only for occlusive and non-occlusive, but all cause mortality. In this registry, 45,000 patients in 4-year analysis, they discovered and find out that diabetes overall risk is much different between diabetes with non-atherothrombosis or prior ischemic events. In this column, there was 19% risk of developing coronary events, while here 12%, and it comes to 9%. So early diagnosis, early treatment will help you to control this problem. In the leader study, Verma and his colleagues, by using the GLP, they find out that single vascular or polyvascular is really different. So polyvascular means you have cerebrovascular disease and stable coronary artery disease. You have more risk than other people. What is the benefit of this study? We can do ankle-brachial index and diagnose early peripheral vascular disease. It will help you to treat these patients early before the events happen. So in TIMI group, this study for thrombolytic therapy, post-MI, they try also their best to differentiate in 11 studies people with diabetes and without diabetes. You look after 30 days, patients with diabetes, they have more mortality than any other group for stable and unstable, STEMI and non-STEMI. And here you can look for the difference, even extend to 1 year. The registry for nurse health study, they register women, and at that time, there is a group of women with diabetes. In this study, 1,500. After the study, almost 5,800 been diagnosed. This is a study for 20 years. If you look for here, they have coronary events even before diagnosis of diabetes, similar to Assaad. So we should treat the patient earlier, and that's why we have the evidence to treat pre-diabetes, which is develop almost 3 times the actual risk. And it will be increased after diagnosis of diabetes and diabetes at baseline. If we go to the second case scenario, Samir, 40 years old male with abdominal obesity, hypertension, dyslipidemia, but a sedentary lifestyle. His HbA1c 6.2, LDL cholesterol 2.3, and blood pressure is controlled. He's on ramipril, atorvastatin, HCT. So pre-diabetes and risk for cardiovascular, primary prevention for diabetes, what we'll do for him, microvascular risk reduction, prevention of diabetes, prevention of heart failure, optimization of risk factors, and the best answer is all of above. What we have tools for Samir, lifestyle modification, change his lifestyle, weight reduction, pharmacotherapy, optimization of risk factors, HbA1c, blood pressure, and lipids. Of course, all of above. So what solution for these patients? We try to prevent diabetes type 2, especially at risk group, as has been illustrated earlier with Professor Nam, like diabetes prevention program. And what we will do, person with pre-diabetes should reduce weight by 5 to 10%, 7% on average, with long-term maintenance at this risk, 30 to 80 minutes daily, at least 5 days a week. A diet that includes calorie restriction, increased fiber intake. Of course, carbohydrate intake limitation is advised. So what we have is studies for this. We have almost a lot of studies. I choose lifestyle 3 trials. They succeed to reduce diabetes and prevent it in 50%, with metformin 26 to 30%, while acarbose and pioglitazone 25 and 48%. These studies showing how many patients you need to treat in this mechanism to prevent. You look for the number to treat, it's 28, 22, 21, and 25. While aspirin therapy, you need to treat 333 people to prevent the events. So I can show you what's the benefit of doing lifestyle modification. In the cardiovascular outcome type 2 diabetes prevention trial, there was almost 89 total events in the diabetes prevention program, in the DREAM program, and the stop non-insulin diabetes, 1.4 events. How many cases? It is 47 cases, and you can look to the difference. By using acarbose earlier, 100 milligram 3 times daily, you can succeed to prevent cardiovascular events, although small number. There is more studies about that, illustrating especially China study. So what pharmacotherapy? My colleague, he explained earlier, we need to control LDL, blood pressure, and other risk factors. So does diabetes prevention program are successful? No, we should be careful because 30% of diagnosed patients already have complications. And one of the major complications are cardiovascular, atherosclerotic cardiovascular disease, which represent almost 80% of diabetes expenditure. So what we will do, we try to reduce the burden of disease, prevent associated complications, improve quality of life. Let's come to Zahra, 54 years old, type 2 diabetes. Now she's 7 years with diabetes, living with it. Smoker, so she has one of these risk factors: overweight, hypertension, dyslipidemia, and gout. Did we get the optimal one? Her LDL is very good, but HbA1c is still high. She started to have symptoms of dyspnea, heart failure, clinically diagnosed, no albuminuria, and she's already on medication: metformin, atorvastatin, losartan, ezetimibe, allopurinol. But what we will do next? Let's look for the evidence. This is type 2 diabetes, how you can prevent them as a primary prevention. Macrovascular, micro, prevention of heart failure, optimization of all this. What you choose for this group of patients? Sulfonylurea, DPP4, SGLT2, GLP, or insulin? Let's look for the evidence. In this, you can look for UK-BDS. The glucose lowering with metformin in obese patients with type 2 diabetes reduce macrovascular disease incidence, reduction in cardiovascular marginal follow-up, original UK-BDS, and again for the blood pressure control studies. So what we need to do, lipid-lowering agents, we need blood pressure control. Aspirin is indicated only for secondary prevention, and generally HbA1c should be below 7. In this study, you can see that even 1% HbA1c reduction can show for you a lot of improvement of reducing the risk of stroke, heart attacks, diabetes-related death, microvascular, and amputation, fatal one. But the problem now we will face when you want to achieve target HbA1c, the hypoglycemia. So what it means, consequences of hypoglycemia, already Professor Samia yesterday, she talked about this. Let's go and jump about talking about Salim. Salim, he did have diabetes for 10 years, and he tried to save himself from the MI, but not succeeded. So he gets STEMI 2015 and CABG 2015. Then HbA1c is still high, 7.8. Is LV also and the GFR being affected, although there is no albuminuria and blood pressure was controlled. What we will do for this patient is on maximum medication. Really, we need to look for secondary prevention, established cardiovascular disease. So we have now rule also for diabetologists to look for these patients. By this way, it comes type 2 diabetes after problem with rosiglitazone in 2008. A lot of studies have been requested from any medication for diabetes to should do an effect on the heart, at least safety. What is the difference? If you look here, there is 1.3. This means agents shown have cardiovascular safety. If it is below 1, confidence interval should be a superiority study. Depends on design. Most of them, they succeed, except Severtimi. They look for the heart failure hospitalization, which was more, and for GLP-1 as well. So basically, Alexa, Leader, all of them, they succeed to do. SGLT2, I will not talk about it because most of the lectures about this subject, Canvas, Declare, all of them succeeded to do secondary prevention, risk factors without established cardiovascular disease. Then what we need to do now is to look what is the message here. SGLT2, GLP-1 receptor, and the other group, sulfonylurea or type 2 diabetes, could be leading for a cause as a major issue, as shown by AASD guidelines. And to take home message, cardiovascular protection type 2 diabetes must focus on MACE, multifactorial approach yield, highest risk factor reduction, and at the end, the guidelines in the medical care for diabetes prevention, it's focused on pre-diabetes 60 years prior gestational diabetes, which is shown in the case of Assaad. Thank you very much.